Dr. Meha to please revise the important concepts.
Thank you, ma'am. Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Today, the topics of my presentations are disability indicators, life table, association to causation, and screening of disease. So, learning outlines will be disability indicators, types of association, types of causal relationship, guidelines for judging causal association, screening of tests and its components. So these are the classification of disability rates. It is mainly divided into two indicators, event type indicators and person type indicators. In event type indicators, we have number of days of restricted activity, bed disability rates, work school days lost within a specified period, and the person type indicators are further classified into limitation of mobility and limitation of activity. Now, the main indicators, disability indicators that I'm going to discuss each one by one. First is HAIL, which is an acronym for Health Adjusted Life Expectancy. Then comes Quality Adjusted Life Years, Disability Free Life Expectancy, and Disability Adjusted Life Years. Health adjusted life expectancy. This indicator is used to measure healthy life expectancy. That is, it is based on life expectancy at birth, but also includes an adjustment for time spent in poor health. So it is defined as equivalent number of years in full health that a newborn can expect to live based on current rates of ill health and mortality. Then comes quality adjusted life years. It is a measure of disease burden including both quality and quantity of life lived. It is used in assessing the value for money of a medical intervention based on the number of years of life that would be added by intervention. And each year in perfect health is denoted as 1 and the death is given the score of 0. So person's length of life weighted by evaluation of their health related quality of life. That is, it is the main components are quality and quantity. So quality is multiplication product of quantity and quality. Then comes disability-free life expectancy, or we can say active life expectancy. That is average number of years an individual is expected to live free of disability if current pattern of mortality and disability continue to apply. Then comes disability adjusted life years. It is the measure of overall disease burden expressed as number of years lost due to ill health, disability, or early death. It is used as a measure by the Global Burden of Disease Project. It is calculated as years of lost life and years lost due to disability. When we add these two components, then we get disability adjusted life years. Years of lost life means that the number of deaths at each age multiplied by the expected remaining years of life according to a global standard life expectancy. And years lost due to disability means number of incident cases due to injury and illness is multiplied by the average duration of disease, a weighing factor reflecting the severity of disease on a scale from 0 to 1. That is severity score. The score is 0, that means it shows perfect health. And if the score is 1, it shows death. So 1 daily is equal to 1 year of health life lost. Here we can see that this daily, that is disability adjusted life years, it is the additive product of years lived with disability, illness, injury, or handicap, like, and years of life lost. So this is, it all comes in disability adjusted life years. The healthy life is not included in disability adjusted life years, or neither healthy life affects the disability adjusted life years. Then life table, it is the life expectancy is calculated using life tables. It is a table which shows for a person at each age what the probabilities of them dying before their next birthday. From this starting point, a number of stats can be derived and also including the table. The other factors that are included are the probability of surviving any particular year of age, remaining life expectancy for people at each age, and the proportion of the original birth cohort still alive. The strength of the life tables is that it's a summary measure of mortality, providing an overall picture of mortality, allowing countries and regions to be compared. However, the weakness is that it is a hypothetical measure that has the potential to be misunderstood by the general public. Then comes our second topic, that is association and causation. It is a stronger the association between exposure and disease than the relationship is causal. There are the three basic types of association: spurious association, indirect association, direct association. And direct association is further divided into a one-to-one causal association and multifactorial association. The spurious association is that it is the observed association between a disease and suspected factor, may not real. For example, study in UK show that perinatal mortality is for 5.4 over 1,000 in home and 27.8 over 1,000 in hospital. So it is somehow linked that the perinatal mortality is more in hospitals. So this association may not be real. So it is spurious association. Then comes indirect association, that is, factor cause a disease, but only through an intermediate step or confounding factor. So there is a intermediate step or confounding factor in this type of association. Then comes direct association. That is, it is further classified to one-to-one causal association. Like, for example, salt intake leads to hypertension. And the another one is multifactorial association, that many factors, many risk factors lead to some disease. For example, many factors are associated with development of lung cancer. There are four types of causal relationship. Necessary and sufficient, necessary but not sufficient, sufficient but not necessary, neither sufficient nor necessary. Necessary and sufficient means that the presence of factor disease always develops, and without that factor disease never develops. That it is necessary, also sufficient. The single factor is sufficient. Necessary but not sufficient, that is, factor is necessary but not itself sufficient to cause the disease. That is, other factors are also required to develop the disease. Then the third type is sufficient but not necessary. That is, factor alone can produce disease. Here in this picture, we can see that either factor A or B or C, any factor alone can produce the disease. That is, it is sufficient, however, not necessary. Neither sufficient nor necessary. That is, factor is neither sufficient nor necessary alone to produce any disease. Then comes the Bradford Hills criteria. There are 9 points. So it is the guideline for judging whether an observed association is causal. We are going to discuss each one by one. Temporal association. It clarifies the order in which the two occur. That is, there should be the length of interval between exposure and disease. For example, asbestos clearly linked to CA lung, but the period is 15 to 20 years. H. pylori clearly linked to chronic gastritis. 11% of patients have duodenal ulcers over 10 years of period. So there is a length of time between the exposure and disease. This is known as temporal association. Then comes strength of association. That is, the stronger the association, the more likely the relation is causal. That is, H. pylori leads to duodenal ulcer, high BP leads to stroke. Dose-response relationship, it is a strong evidence of causal relationship. For example, here we can see that the pre-hypertension, moderate hypertension, severe hypertension, and here is the doses of the. Then the replication of findings. We would expect to find it consistently in different studies in different population. For example, observation regarding H. pylori have been replicated repeatedly. Then consideration of alternate explanation. To which extent the investigator have taken other possible explanation to count and rule out such explanation. For example, data suggests that smoking can increase the risk of duodenal ulcer and H. pylori. So this is here the alternate explanations being considered. Then comes biological plausibility, that is, causal association is supported if there is biological credibility to the association. For example, originally it was difficult that how bacterium invades, but now it is recognized that H. pylori binding sites on androgen follow these cells to the duodenum. So there is some biological relation behind this association. Cessation of exposure, that is, if risk of disease decline when risk of disease declines when exposure to the factor is reduced or eliminated. For example, eradication of H. pylori heals duodenal ulcers at the same rate as histamine receptor antagonist. Then consistency with other knowledge. We would expect the findings to be considered consistent with other data. For example, prevalence of H. pylori infection is the same in women as in women, men as in women. Prevalence of H. pylori is much higher in developing countries. Then specificity of association. That is, certain exposure is associated with only one disease. That is, exposure is specific for the disease. Like prevalence of H. pylori in patients with duodenal ulcer is 90 to 100%. Then comes our other topic, that is screening. The search for unrecognized disease or defect by means of rapidly applied tests, examination, other procedures in apparently healthy individuals. So this comes in screening. That is, today's screening is considered a form of secondary prevention. As we all know that the interventions for secondary prevention are early diagnosis and prompt treatment. So screening comes in early diagnosis. It detects disease in its early asymptomatic or preclinical phase, whereby early treatment can be given and disease can be cured or its progression can be delayed. As we can see that this is the natural history of disease, and here there are different preventive measures taken at different stages. So at the preclinical phase, we can do screening as a form of early detection, and we can catch the disease in its early stages, and we can treat timely. Lead time. The advantage gained by screening, that is, it is the period between diagnosis by early detection and diagnosis by other means. That is, we can see that this is the lead time. This is the time when the disease is usually diagnosed. But if we diagnose it earlier due to early screening, then the time gained is the lead time. So screening programs work better where the time lag between the disease onset and its final critical point is sufficiently long. These are the uses. That is, it is used for case detection, the presumptive identification of unrecognized disease which does not arise from a patient's records. For example, neonatal screening. Then comes control of disease, screening of immigrants from infectious diseases like Ebola, TB, syphilis to protect the home population, screening for HIV, STDs. Then for research purpose, that is to know the history of many chronic diseases like cancer, hypertension. Initial screening provides a prevalence estimate and subsequent screening provides an incidence figure. Then screening programs helps in acquisition of information of public health relevance, public awareness for educating health professionals. Then comes types of screening. First is mass screening, application of screening tests to large unselected population. Everyone in the group is screened regardless of the probability of having the disease. For example, visual defects in all schools children, mammography in women, colonoscopy for occult blood. Then comes high-risk selective targeted screening. That is screening of selected high-risk groups. For example, screening fetus for Down syndrome, mother who already has a baby with Down syndrome. Screening for familial cancer, screening for CA, cervix, and low socioeconomic status women, screening for HIV in risk groups. Then comes multi-purpose screening, the screening of population by more than one test done simultaneously to detect more than one disease, like screening of pregnant women for HIV, HPV. Then comes multi-phasic screening, screening in which various diagnostic procedures are employed during the same screening program. The criteria for screening. The criteria for screening is based on two considerations: disease, screening test. Disease. The disease should be important public health. That is, it should have a high prevalence. For example, TB. Disease should have long detectable preclinical stage. Natural history of disease should be adequately understood. Appropriate tests must be available for early detection of disease. Facilities must be available for diagnosis of disease. Early detection of disease and treatment should be able to reduce mortality and morbidity. Disease should be treatable, and there should be recognized treatment for lesions identified following screening. Expected benefits must exceed risk and cost, and a policy should be agreed on concerning whom to treat as patients. Then comes the second criteria, that is screening test. It should be inexpensive and easy to apply, acceptable, valid, reliable, yielding. Simplicity. It means a test should be simple to perform, easy to interpret where possible, capable of use by paramedics and other personals, like blood and urine tests and ECG for early detection of hypertension. Acceptability. Since participation screening is voluntary, so tests must be acceptable to those undergoing it. In general, tests are painful, discomforting, embarrassing. They are usually not acceptable. Then comes validity and reliability. Validity means the accuracy of a test or ability of a test to distinguish between those who are diseased and who do not have disease. And reliability is the precision of a test, or we can say the repeatability of the test. If we perform the same test repeatedly, then the replication of findings, it comes in the reliability. Validity determines the accuracy of test. A test with little systematic error is a valid test. Components of validity, sensitivity, specificity, and predictive accuracy, which we are going to discuss further. The sensitivity, it is the ability of a test to correctly identify those who have the disease. That is, it identifies true positives, or we can say the proportion of truly ill population. Here we can see that those who are tested positive, then this is the the box of the grid. It shows that these are the patients out of the patients who are tested positive. These are the patients who actually have disease. So this true positive, it indicates over like this is a true positive, and as a denominator we will keep all the positives. Then we get sensitivity. Specificity, the ability of a test to correctly identify those who do not have the disease. That is, it identifies true negative. And the method of calculating specificity is that we put true negatives as numerator, and then we put all the negatives, like we true negatives as well as false positive. Sorry, true negative and false positive we put as denominator, and this is how we calculate specificity. This is how we are calculating sensitivity. That is 80, that is true positives, and we are calculating all those who we are putting all those who are diseased as denominator, and the sensitivity here is 80%. And for specificity, we will put true negatives as numerator, and all those who are not diseased, they will be put as denominator, and this is how we will calculate specificity. So an ideal screening test should have 100% sensitivity and 100% specificity. However, it is not practically possible. False negatives. If a person with disease is labeled negative, then false reassurance ignores any disease, sign and symptoms, postponement of treatment, detrimental to overall health. And false positive, if a person without disease is labeled positive, then what happens that they further testing, if the patient is called for further testing, and they're long, expensive test, discomfort, inconvenience, anxiety, burden on health facilities, emotional trauma, and then afterwards when they are repeated tests, then he is labeled as negative. So there is difficulty in delabeling. So there are two types of, like we can say that there are the tests which are either positive or negative, like bimodal distribution. And there are some tests whose results, like for continuous variable, like we can say for hypertension, the results are continuous. There is unimodal distribution. Concept of cutoff point. Unlike in bimodal distribution, which is dichotomous, some diseases comes in continuous variables like diabetes, hypertension. In these cases, difficult to calculate sensitivity and specificity. So a cutoff point is set to distinguish between positive and negative. For example, consider 20 diabetics and 20 non-diabetics screened using a blood sugar test from low to high. Then if there is low cutoff point, here we can see that the cutoff point is low. The sensitivity is 85% and specificity is 20%. False positive originated, more non-diabetics are diagnosed positively. Here we can see. Now, if cutoff point is high, then we can see that the false negatives originate, more diabetics are not diagnosed positively. So for high cutoff point, then the obviously sensitivity will be reduced. So obviously that the more diabetic patient, more disease patients, they are not diagnosed positively. So different cutoff points yield different sensitivities and specificities. The cutoff point that identifies more true negatives will also identify more false negatives. The cutoff point that identifies more true positive will also identify more false positive. The choice of a high or low cutoff level for screening therefore depends on the importance we watch to false positive, false negative. But in case of lethal diseases, like in case of carcinomas, where early intervention is possible, cutoff point must be set at low so that as greater sensitivity required, false positives can be tolerated. So that more true positives can be diagnosed earlier. That's why we set the cutoff at low level. Okay, for screening of the disease, there are usually two types of tests. Multiple tests, sequential tests, then comes simultaneous tests. In sequential tests, the tests are performed in two stages. The patient undergoes the test initially, easy test, rapidly performed test. So after the first screening test is conducted, those who test positive are brought back for second test to further reduce false positives. So the overall process will increase specificity but will reduce sensitivity. So this is the point to remember, that in sequential testing, net sensitivity falls, but net specificity will be gained. Simultaneous testing. In this, two or more tests are conducted parallel. The goal is to maximize the probability that the subjects with disease, two positives, are identified, that is high sensitivity. So in this, net sensitivity is gained in simultaneous testing, but net specificity will be lost when compared to either of the tests. Then comes predictive accuracy. That is positive predictive value, negative predictive value. Positive predictive value is the proportion of people who screen positive that actually have the disease. It means that the people with disease, are they correctly identified? Then comes negative predictive value, the proportion of the people who screen negative that are actually free of disease. These values are not fixated for a particular test. So here we can see that how we are calculating positive predictive value. That is, we are putting 80, that is, here we can see the two positives as numerator, and we will put the all the patients who are positives as denominator. That's it, 80 by 180. That is 44% is positive predictive value here. For calculating negative predictive value, we will put two negatives as numerator, 800 here we can see, and total negatives will be put as denominator, that is 820. And here in this case, we are getting the value 98%. So predictive accuracy depends on prevalence of the disease and specificity of the disease. So there are the two main factors that affect the positive predictive value, that is increase in specificity and increase in prevalence. They demarkedly increase the positive predictive value. Then comes the reliability. Reliability determines the precision of tests, that is repeatability. It means that all the tests of the test should be similar at cluster at one point when conducted each and every time. This is not possible because of the variation that cause a test to not yield same results every time, as there are three types of variation: intra-subject variation, intra-observer variation, intra-observer variation. Intra-subject variation. This is a variation in the results of the test conducted over time on the same individual. The difference is due to the changes that occur to the individual over that time. That is the individual that is testing that is being tested. The variation is due to, for example, if a doctor is measuring the BP of a single patient, and there is variation in the measurements over the 24-hour period, then this is intra-subject variation. Intra-observer variation. This is the variation in the results of test due to same observer examining the results at different time. Two readings of blood pressure by the same observer. Inter-observer variation. This is the variation in the results of the test due to multiple observers examining the result. For example, chest X-ray read by two different radiologists. So they can interpret differently. So this is the graphical representation. Here we can see that these test results, these are valid but not reliable. The those tests which are near the true value, they are valid. And the where there is a peak in the graph, that is results are repeated findings, then the clustering of the test at a single point, it shows that this is reliable. So here the test results are valid but not reliable, and here test results are valid and reliable, and here the test results are reliable but not valid. So reliability of test, there are different types of reliability. There is one type, that is inter-rater reliability. It is the level of agreement between raters. Two raters, overall percent agreement is measured. For example, there are two raters. We will calculate a percent agreement, that is observed agreement or over possible agreement. For example, we can see that there are two observers. So at 2 points, there are two chances that they will be agreed together, that is at point A and D. So we will add A plus D over total finding, that is A plus B plus C over D. So here we can see that this is the percent agreement, how percent agreement is calculated. Because D, that is because most are non-disease people, here the two raters are agreed that most non-disease people. So ignoring this D equation, we can see that this is the percent formula for the percent agreement. And this is the formula for kappa statistics. It observes use different criteria. Observer would agree solely by chance. It is percent observed agreement, which we have just calculated, and then minus percent agreement expected by chance over 100% minus percent agreement expected by chance. This is how kappa stats is calculated. You people can go through it later. Now coming into multiple choice questions. MCQ number 1. A program manager from an international health funding agency needs to identify regions that would benefit from an intervention aimed at reducing premature disability. The manager asks a healthcare consultant to develop a proposal using an index that would help her make this decision. Which of the following would best serve this purpose? Health-adjusted life expectancy, disability-adjusted life expectancy, quality-adjusted life years, standardized mortality ratio, physical quality of life index.
A.
E. No. B is the right option. Disability adjusted life year. As we can see that here the program manager needs to identify regions that would benefit from intervention aimed at reducing premature disability. So in disability adjusted life year, it deals with premature disability, handicapped, and being ill health. MCQ number 2. H. pylori clearly linked to chronic gastritis. 11% of patients have duodenal ulcer over 10-year period. Temporal association between a risk factor and the disease relates to dose response relationship, duration response relationship, one-to-one cause relationship, cause and effect relationship, multifactorial relationship.
D.
Yes, D is the right option. MCQ number 3. H. pylori is widely regarded as necessary cause of gastric adenocarcinoma. However, not all patients infected with this bacterium gets carcinoma. This shows that in addition to H. pylori, individuals need to be exposed to other risk factors. Which type of causal relationship is shown here? Here you can see the picture and kindly tell that what type of causal relationship is shown in this scenario.
B.
Yes, yes,
B?
B is the right option.
D.
MCQ number 4. Results of screening test for diabetes compared to confirmatory test, OGTT. The specificity of test is 96.1%, 86.1%, 76.1%, 56.1%, or 66.1%. It requires some calculation. Here we can see that 500
It's
by
specificity,
520.
so it would be high, yes.
Yes.
Yes, I was telling the same thing. It would be 500 over 520.
Yes. Here we can see two negatives over all the patients were non-disease, 500 over 520. So we will get 96%. A is the right option. MCQ number 5. A comparison of clinically diagnosed versus autopsy confirmed gastric and peptic ulcer were performed or 750 consecutive disease patients, several large hospitals shown the following table. From these data, sensitivity of clinical diagnosis is. Here you have to calculate sensitivity. It's very easy. Numerators and denominators. It is given in the form of numerators and denominators.
100 divided by 250.
Yes.
Option
Yes,
D would be
exactly
done.
right. Yes, D is the right option. MCQ number 6, results of screening test for hypertension in the ABC community. The sensitivity, again, it is the sensitivity of test. 23, 33, 43.3%, 53, 63.3%.
It would be 100 divided by
It would be
300.
100.
Yes, let's see. 100 over 300, that is 33.3%. B is the right option. MCQ number 7, results of screening test for prostate cancer XYZ community. The PPV, that is positive predictive value test. Now, what will be the numerators and denominators? Anyone?
250 over 600.
50 over 600.
Yes, right.
It would be,
41.6.
yes, 250 by 600.
Yes, A is the right option. Result of screening test for breast cancer in the ABC community. Now it is, they are asking for negative predictive value of test. Anyone?
Yes, it would be 200 divided by 350.
Yes. 57.1. Yes, C is the right option. MCQ number 9. Hypertension is rising in the XYZ community. The health department started a screening program for hypertension. Hypertension screening is more productive and efficient when performed on high-risk population because the more prevalent disease has high PPV, low PPV, low NPV, low NPV, and low sensitivity. High prevalence leads to, yes, high positive predictive value. It's the right option. Yes, right. MCQ number 10. A screening test is used in the same in two similar populations, but the proportion of false positive results among those who test positive in population A is lower than those among those who test positive in population B. What is the likely explanation for this finding? It is impossible to determine what caused the difference. The specificity of test is lower in population A. The prevalence of test disease is lower in population A. The prevalence of disease is higher in population A. The specificity of test is higher in population A. Anyone?
Charlie?
C.
Oh. The proportion of false
D.
positive results among
Delta.
yes, D. Yes, D is the right option. Yes. This is the key of MCQs. This is the YouTube link of the presentation, and thank you.
Thank you so much, Dr. Meha.
Thank you everyone for patient listening. Allah Hafiz everyone.
Allah Hafiz.
Thank you so much, Dr. Meher. It was such a nice presentation.
Thank you.